Hello from the Heartland. My name is Jenna, and this is Smarter News. News when it matters and why it matters. Our Smarter series features unique people who help us think and live smarter. Welcome to our first Smarter News Live of 2022. I'm really excited about this. We have Dr. Rutland back with us again, pulmonologist, father, and a great friend to Smarter News over really the last 18 months, taking a look at the pandemic. And when we talk about primary sources as a journalist, that's what we're always looking for. A primary source is a source that is closely connected to a topic, that has firsthand experience with it. And so Dr. Rutland is the primary source when it comes to understanding the coronavirus as a virus, but also the disease that it causes or the illness that it causes, COVID-19. We're going to use those terms interchangeably. We do that a lot between SARS-CoV-2, the virus that causes COVID-19, the illness. Remember, COVID-19 is sort of a made-up term by the World Health Organization. Coronavirus disease 2019, that's what it stands for. And so sometimes we refer to COVID, really talking about the virus. Sometimes we're talking about the virus, talking about COVID. So just always like to refresh us on that. Dr. Rutland is particular about that. And I'll bring him in just a moment. You know, one of the things that I always think about when we start off an interview is that one fact, that one data point, that one news hook that really grabs us, that we can kind of start the conversation and accelerate from there. And as I was thinking about that this morning, I thought, you know, there isn't that one data point that can do that for us right now. We're at an interesting point of the pandemic, one that many maybe didn't think we would be at, with another variant that's causing a lot of infection, but seems to be behaving somehow different than previous variants. And any data point I could give you at this point is backwards looking. We always have to remember that about data. It's not a snapshot usually of right now. It's a snapshot of yesterday or last week or last month. And for particularly a virus and an illness that we've been seeing through the pandemic that has a long incubation period, that kind of goes out, let's say, over a period of 3 to 4 weeks, sometimes that data is not as helpful for really understanding what's going on and how that impacts our family. So I'm going to throw that all away, and I'm just going to use your questions to drive this conversation. I want the news to work for you again. We're building a solution in news when it comes to Smarter News. And I just want your questions answered by a great source. So let's go ahead and get Dr. Rutland in and see better serve you, because that's what this is about. It's about customer service. A lot of industries are really about customer service, even when we don't think about it. And that includes medicine and includes journalism. Hey, Dr. Rutland, looking sharp in your suits. You always dress up for us, which I appreciate.
I do. I mean, I think Smarter News is a serious media outlet, needs to be taken seriously. Even, you know, I like the new white Smarter News hoodie.
I know. I just talked to Dr. Rutland before we jumped on, and I said, listen, I had big plans. I was going to look really professional today. And then my 2-year-old, who happens to be the biggest fan of Dr. Rutland that exists, by the way, True Babbitt loves him some Dr. Rutland. I've been kind of hands-on as a mom today. So that's one of the good things when you develop your own news platform, is I wouldn't be able to do this in other areas, but here it is. This is real life. And this is what a lot of families are going through, Dr. Rutland, which is repeated respiratory illnesses, which is what my 2-year-old has right now. So I want to get to our questions, but I want to just ask you quickly, what is your big takeaway for this moment that we're in, having gone through a couple of weeks of seeing Omicron and having lived through the pandemic thus far? Bottom line, what's your headline coming out of these times?
You know, my headline is hospitalizations are on the rise, but disease severity doesn't seem to be worse. That's kind of how I would put it. You know, it's interesting because I was actually in the hospital this morning, right? At 5 o'clock this morning, because I knew I had to do this. I knew I had to do some other filming today. So I said, you know what, I'm going to get up at 4. I'm going to go to the hospital. I'm going to get all my rounding done, go see these people. And I was on the floor, and one of my patients, actually a few of my patients, have coronavirus. And I asked the nurses, the charge nurse, and I'm like, hey, how's it going? They're like, oh, it's just half of this floor, half of another floor, and then our typical coronavirus floor. And so when I think about the peak of the pandemic for our hospital where I round, it's not the same. It's completely different. It is not every single patient with coronavirus. That's one. And then the second thing, and we talked about this a little bit this morning, is at least in New York, it was released on Friday that 42% of the cases admitted SARS-CoV-2 was incidentally found. In other words, they came in with something else. So I thought that that was interesting as well. Now, it doesn't mean that SARS-CoV-2 has nothing to do with what they came in with. It just means that it doesn't seem to be causing that severe respiratory illness as it had previously. And when you look at the data in South Africa, that seems to be so, right? There's kind of two different cohorts that they've looked at. We'll get into that, I'm sure, a little bit later.
When can you say that with confidence? You know, we've kind of been hedging all of the information thus far, that South Africa seems so far that the severity of illness isn't really there. You know, we've seen that so far, at least when you talk to doctors that are actually treating COVID-19 patients. Like, when can we put our shoulders back and say, yeah, actually, so far and indefinitely right now, it's not causing the same severe illness, at least this variant isn't.
Kelsey, wife is leaving. You could definitely say it's not causing as severe illness. Like, that's 100% true. You can say that when you look at the pathogenicity of this organism. It does not like to infect the type 2 pneumocyte, which is the cell that your alveoli, your lung balloons are made out of. It likes to stay in the upper airway. Now, because it likes to stay in the upper airway, that probably has something to do with transmission, right? It's a lot easier to transmit and has those characteristics. So a lot more people have it. So a lot more people are positive for SARS-CoV-2. You're going to see that. You're going to see them in the hospital. You're going to see all of that. But the disease, honestly, it is not as severe. In fact, when you look at the patients, at least the patients that I know about that are in our ICU, these patients presented before Christmas. Well, what does that mean? Well, before Christmas, the ratio of Delta to Omicron was like 40% Delta, 60% Omicron. Now it's like 95% Omicron, 5% Delta. But that had something to do with it, right? So they all presented, not all, but most of them presented with Delta-related coronavirus, which led to 2 weeks of being in the hospital and the disease just progressing. And now they present to the ICU, which is typical, which is what happens to these patients. So, again, you could definitely say it's less severe. The impact on healthcare, that doesn't mean the impact is less severe. It just means the disease itself. If you were to get SARS-CoV-2 right now, and you called me, it may or may not have happened, and you called me, that would mean that I would not be as worried. I would still be concerned, but I wouldn't be as worried, if that makes sense.
Okay, well, Belinda's actually writing that right now, and she says that right now she's actually COVID positive. And she's like, what do I do? And that's one of the big questions we got from our audience, Dr. Rutland, which is people are testing positive. In fact, a lot of people are testing positive or have symptoms that aren't testing positive, but kind of know this, I was around someone with COVID. And like, what's the plan? You know, what is the plan? What am I want to do the right thing. What am I supposed to do? I'm not talking about social distancing and quarantine and all. I'm just talking about, like, do you take a Tylenol? Do you take a vitamin C? Do you take zinc? Like, what is the plan? How would you answer Belinda? I know we don't know Belinda. Belinda, I hope you're feeling okay. Thanks for joining us. What would you say to someone like her that says, hey, I just tested positive? Like, what's my plan?
So first and foremost, Belinda, I do hope that you're okay. And this is a text message or a phone call I get every day from all my friends, right? So what I tell my friends is, first of all, I have to understand their risk factors. Do they have risk factors for severe COVID, right? Those risk factors, as we've talked about many times before, include being over 65, having a BMI over 25, having diabetes, having hypertension, being immunocompromised, having chronic liver disease, chronic kidney disease, chronic lung disease, right? Where organs are suffering. If you have those risk factors, then I'm more concerned. If you don't have those risk factors, I would treat it as you would treat a cold. I would use decongestants. I would use NyQuil. I would use, Flonase if you want to. I would use things, a lot of people are having a sore throat, so I'm telling them to go get that Chloraseptic or whatever it's called these days. I don't know. I'm 40 years old, or who knows what it's called now. But that numbs the back of your throat just to kind of help you deal with that pain. So I'm treating people with a cold, but I'm also taking into account when their symptoms started and if they have risk factors for severe disease. And then the other thing I'm thinking about is, do they have a history of autoimmune disease? Is this going to activate an inflammatory response that's going to persist? And do I need to pay attention to this and perhaps give them more aggressive immunosuppression to calm down the inflammatory response after about 7 to 10 days? But these are the things that are running through my head, right? Not everyone I'm worried about needs to rush to go get these antivirals or these monoclonal antibodies or anything like that. But I do want people to be evaluated, especially people within my community that know me and I'm their physician.
Is there any over-the-counter medication that could do harm for families out there that are thinking, okay, like, okay, NyQuil, I got that. I can do chloroseptic, but is there anything that you could do harm with?
Mm-hmm. Yeah, there's over-the-counter medications that you can do harm with. The thing about over-the-counter medications is it's very, very difficult to do harm, except there are medications like Tylenol, acetaminophen, right? Tylenol can be extremely liver damaging and liver toxic if you take too much of it, right? That is an issue. So you want to make certain that when you're taking these medications, you look at the back and look at the ingredients. If it says acetaminophen, you want to pay particular attention to that, and you don't want to take any more than about 3 grams a day of acetaminophen. You don't want to take any more than that a day, because upwards of that, you're going to start to develop liver toxicity and things of that sort. Not everybody, and you're probably safe if it's a little more than that, but for the most part, you want to pay attention to those ingredients. That's why I always say if you have these home infections, and most of them are at home, you want to be able to just use over-the-counter medications at the doses that they recommend.
We're getting a lot. It's really fun to see where people are joining us from all over the country, the Smoky Mountains, Utah, Texas. So you guys go ahead and post where you're talking to us from, because it's nice to see how big the community is and how many people we're reaching. And they really understand that even though the pandemic has divided us in a lot of ways, it's also given us something that we share. You know, we're all trying to navigate this. One of the things that we're trying to navigate as families, Dr. Rutland, are these at-home tests. And I just talked about it today on our morning report. It's something that really has entered into the news cycle over the last 24 hours, this idea that maybe with Omicron, these nasal swabs aren't the most effective, that because of the throat irritation, for whatever reason, that might be the better place to test. And in fact, the UK has a video out which just shows you that you should swab your throat, and with that same swab your nose, which just freaks me out. Just admittedly, I don't like to get editorial, but that I'm like, how many places can I swab? I mean, I'll do whatever you want, but just get me an accurate reading. What do you think of this news? Do you think it is something to the swabbing in the right place to really understand who's positive and who's not?
So 2 things. I just want to bring up an important point, because there's a couple of people that commented and said, you know, fevers are good. Fevers are good. I 100% agree with them. One of the things we do over-treat is fever, because what a fever does is raises the body temperature to not allow organisms that aren't used to being that hot, to not allow them to grow and not allow them to replicate, because they don't like to replicate in that environment. So having a fever is important. So I agree. I am more likely to allow my patient to have a fever than not. In fact, when I get a call from the ICU nurses at night, and they tell me that a patient with infection has fever, like, I'm going to be honest, most of the time I don't care. I'm like, they're supposed to have a fever. That's what I want them to have. I don't try to bring it down unless it's dangerously high, like 105 or 106, or like my kid had as a baby, febrile seizures. Now, going to your point of testing, this is very important. And for me, this is common sense. When you are testing yourself at home, if you have a sore throat and your nasal passageway is fine, test your throat.
Really? Right? You could just do it like with the at-home test. You don't have, I mean, the directions don't say that.
I know the directions don't say that, but that's what I would do. There was actually some tests in which patients would test their throat and test their nose simultaneously, and their throat was positive and their nose was negative. So I think it's really, really important. In fact, my little brother had SARS-CoV-2 infection last week. His girlfriend had it that was visiting from Texas. His girlfriend had it, and then he got it. And he was like, my throat is sore. And I was like, test your throat. He's like, my sinuses are fine. I said, test your throat. His throat was positive, right? So again, it's important to pay attention to those specific symptoms. And I would totally do that. So I would take the strategy that you just suggested. I would swab my throat, and then I would swab my nose. If you want to go vice versa, all power to you. It's not that you can't do it, but then you're just going back to those days when you were True's age, you know? And that's okay.
I just, you know what? We've all just, we just there's nothing left. There's no secrets left anymore. We're just swabbing as much as we can. But this really comes to, I just think it's interesting we're talking about this now. By the way, I also noticed that little dig about the girlfriend being from Texas. I just want to tell you that I've noted that.
That's not a dig.
It was a little bit of a dig.
She's
I know you were
vaccinated
describing,
and boosted.
I think our audience felt it too. I'm just kidding. It's always the girlfriend's fault. This is what it
No. I know where he
behavior.
We talked about where he got it. We talked about it already. I was not going to be loud about it, but I talked to you about it. It was our other brother.
So yes. So this has come up repeatedly amongst our viewers that have been asking questions about it. In fact, I had one that I just wrote down because I thought she did such a great job at mapping it out. It's Hello Meg. She said, how can an at-home test be positive? She had an at-home test 24 hours apart. Both of those at-home tests were positive. Then she went and got a PCR test. Sometimes you need a PCR test for traveling or for your work or something. So then she goes and takes a PCR test. The PCR test is negative. So this spans out over a 72-hour period. What gives? What's going on with some of these tests, Dr. Rutland?
Yeah, so the PCR test tests for viral remnants, and you got a test for RNA remnants, and you want to have RNA, and then they basically replicate the RNA. There's a certain cycle threshold that we call positive, and if you reach that cycle threshold, it's positive, right? So if you don't have enough RNA in there, you're going to be negative. The antigen test, quite simply, tests for like spike protein or nucleic acid protein, tests for an antigen on the virus, and if it's present, it'll be positive. So they're two kind of completely different tests, and they're really not related with one another. The way that I look at it is like this. First of all, I know the CDC says don't use the nasal test for the throat. That's fine. It's great, but common sense. Anyway, the way that I look at it is like this. If you have symptoms and you're positive. If you have symptoms and you're around somebody that had it, you probably have it. Doesn't really matter what your test says. Tests can be wrong. I mean, just think about how many tests are going out, right? How many people are testing? There is a certain amount of error that you're going to have, or you just might not be positive that day. It doesn't mean you don't have it. You don't need to, if your spouse has it and you're negative and they're positive and you're both displaying symptoms, you both have it. It doesn't matter really what your test says. That's what I say. You have it, do the quarantine as indicated, move on from there.
So over the holidays, we're talking a little bit about this because the rush to get tested causes such long lines, and it's frustrating for people. I mean, we have spent the last 18 plus months being told to get tested. And then when you can't get a test in a drugstore, there's such a long line, it's taking you 3 hours to get through. Even if you have symptoms, you kind of want to know. There's like a part of this, it's like, I want confirmation, Dr. Rutland, that this is really what it is, So what do you think of that push-pull on like having to get a test? My 2-year-old obviously has a really bad cough. I will probably test him. He has a doctor's appointment in the morning. He's never tested positive through this entire time and through multiple rounds of the pandemic in our household. So, but he has a bad cough. It's croupy. So should I just assume he has it? I think a lot of parents are asking that on our writing and questions of like, do we just assume at this point? And that's something that Laura was asking, is basically everyone going to get this? Should we just think that way?
Yeah, it seems like basically everybody is going to get this. And do I assume a positive test at this point, especially if you're around people that have it? I do. Like, I wouldn't go stand in a long line. I wouldn't suffer if you're trying to find a test. I would assume you have it and treat yourself accordingly depending on your risk factors. So that's what I would do, because I just think that at this point in time, I try to be reasonable. I'm not trying to, I'm evidence-based, but I'm evidence-based and reasonable simultaneously. I'm not trying to say, oh, you need to have a test to make sure that you have it or not. Like, I get the work rules. I understand that. I understand going back to work. I get all of that. If you have to do it that way, that's fine. Hopefully they provide you a test and they have a bank of tests to be able to provide you. But if they don't, I would quite simply just say, okay, my friend had it. I was at dinner with her. I have symptoms 2 days after dinner. I probably have it, right?
Interesting.
And then I would behave accordingly. Yeah.
So let's move on to a couple of these questions. Sabrina was asking, and this was, you had shown something on your social media, which showed what a lung looked like when there is severe illness. And you could see the fogginess in the lung. You could see what was happening to this person with this infection. Sabrina was asking that her son had COVID. He's very young. He's an infant. If there's any reason to take a closer look at your lungs, if you tested positive in the past, your child tested positive in the past, to see if there's any sort of long-term damage. Is that something that you would just experience, or is it something that you think that we should check? Are you seeing that there are lasting impacts even when people don't feel bad, that maybe their lung does have damage, because even with a mild case of COVID, it could cause that?
Yeah, it's such an interesting question. I'm biased. I take care of autoimmune lung disease. That's what I do. To be able to take care of autoimmune lung disease, which, to be honest with you guys, essentially COVID is an autoimmune lung disease. It's activation of the inflammatory response, which causes a rush of white blood cells into the lung. And that's what you see on that x-ray and on that CT I showed you, is you see evidence of inflammation. Those are all white blood cells rushing to the lung. So because of my bias and because of what I do on a daily basis, I'm always going to get that HRCT. I'm always going to at least get a chest x-ray to look for evidence of lung inflammation. I'm going to do that. In fact, I do it so much that when I get a consult on a COVID patient and the patient hasn't had a high resolution. Not disturbed. Are we good?
Yeah, we're good.
Okay.
Sometimes the phone calls interrupt the audio, which has gotten me a couple times, but we can still hear you.
Okay, good. So when that happens, when the patient doesn't get a HRCT, I actually get really kind of angry. And I'm like, we need to get the HRCT. We need to attest to the level of inflammation that's in the lung, because I have to understand, what am I going to do long term? Am I going to heavily immunosuppress this patient or slightly or whatever? Because I don't want damage to occur in the lung. But again, I am a very proactive guy. In other words, in all of my physician colleagues that I know, I tend to do things a lot earlier than they do, just because some colleagues wait for symptoms to occur or wait for people to get worse before they do something. I tend to do it earlier. And who knows if it's, if my way is right or their way is right, or there's a gray area in between, doesn't really matter. But that's just how I practice, because I deal with the immune system and its response. Yes.
Michelle wanted to know, does COVID actually cause new inflammation, or is it exacerbating old inflammation? And what is getting people actually in trouble?
What a great question. It's causing new inflammation. New inflammation in the sense of, when you think about the way the body works, all right, let's just focus on the lung. I'm a pulmonologist, so that's where we're going to focus now. The lung is essentially a bunch of balloons stacked on top of one another. That's the lung. If you go to Disneyland and you see the guy at the end of Disneyland, like right when you're about to go out, when party's over, everybody had their corn dogs, everybody is ready to go. The parents are especially ready to go home and sit down. The kids are still wanting those last minute things. They look at the balloon man who's got like 10 balloons. They're holding up all these Mickey Mouse balloons and they're all stacked like next to each other. That's kind of how the lung is organized, right? The balloon man is kind of the pipe that's carrying air to the balloons, right? So when you look at those balloons are normally filled with air. They're empty. They're just full of air. You take a deep breath in, oxygen gets in there, diffuses across the balloon membrane there to get in your bloodstream. That's how the lung works. What happens with inflammation is the white blood cells clog up those balloons, right? So you have all these white blood cells in those balloons trying to fight off this coronavirus, and that's new inflammation. And that's what causes you to be short of breath. That's what causes you to cough, because that inflammation is not only in that balloon, but it's also in that pipe that's carrying air to the balloon. So you cough, you wheeze, you become short of breath, right? I had a pregnant patient, 15-week pregnant patient, presented with an asthma exacerbation secondary to SARS-CoV-2. She had SARS-CoV-2, right? Didn't have any nasal symptoms, just had asthma exacerbation. She was intubated, and we had to immunosuppress her and calm down her inflammatory response. Now, let me tell you something. Intubating a pregnant patient and taking care of mom and baby is one of the scariest things you can possibly do in the intensive care unit.
Yeah,
because
it sounds like it.
Yeah, although we're taught to just take care of mom, right, and don't really worry about the baby, do everything you can for the mom, it'll help the baby, you're still thinking about both. It's pretty hard not to think about both. So that's a very scary thing. She's extubated, she's doing well, she just needs better asthma management. But those are the types of things that lead to new inflammation.
So it's new inflammation. So if you are someone that has inflammation in your body, it's not like the catalyst for that inflammation too, or can it be?
It can be. It can be. So I was really worried about my autoimmune lung disease patients because they already have that tendency to have inflammation in their lung. Now you take into account the virus on top of that, they already have scarring. They already have a baseline of inflammation. And now you got new inflammation on top of that. So they're going to be in the hospital, right? So I really had to look after them and make certain that I had therapies available for them to treat them early. Like I gave a patient that has rheumatoid arthritis who also has interstitial lung disease and pulmonary fibrosis. She presented last week with asymptomatic SARS-CoV-2. She had no symptoms, right? Her son had it. She was like, I should get tested. She got tested. She was positive. I gave her sotrovimab like right away. She didn't have any symptoms. I don't care. I don't want her to have symptoms.
What is that?
So sotrovimab is a monoclonal antibody that inhibits the spike protein from binding, and it's the one monoclonal antibody that we know 100% neutralizes spike protein in Omicron.
So Eva's asking about natural immunity, and she said, please talk a little bit about this.
Sure.
At this point now, we're seeing reinfection. We're seeing infection, double vaccinated, boosted people. We're seeing infection for people with prior infection. So what is this doing to community immunity? How do you see it?
Yeah. So natural immunity does matter. And so just to explain the concept of natural immunity, when you look at SARS-CoV-2 as a whole, right, we know it's a negative sense RNA strand. So what it is, or positive sense RNA strand, what it is it's a big virus that has structural proteins around it, right? Spike, nucleocapsid, membranous envelope. When you're naturally infected, you don't have any antibodies towards anything. Your body looks at this whole virus, cuts it up into pieces, and creates antibodies and T cells to recognize many different aspects of it. Some structural proteins, some non-structural proteins, some whatever, right? T cells recognize it. Antibodies, B cells, they all recognize the entire thing. That's natural immunity. So when you check the antibody levels for, like, let's say, for instance, the spike protein, it's not going to be as high as it's going to be in the vaccine, because with the vaccine, all you're giving the immune system is spike. So it's going to raise that antibody level really high. Natural immunity, you're going to see spike, you're going to see, open reading frames, you're going to see membranous, you're going to see nucleocapsid. There's going to be many different antibodies to many different things, right? So when you compare the antibody levels, it's going to be greater in the vaccinated people just because of that. We're only vaccinating against the spike. But natural immunity does protect you somewhat, right? It does lead to some recognition of SARS-CoV-2. In fact, there was a study published yesterday in Nature that showed cross-reactivity of T cells that recognize other coronaviruses, right? There's 7 coronaviruses that infect human beings. 3 of them are very severe: SARS-CoV-1, MERS-CoV, SARS-CoV-2, but then there's the common cold coronaviruses, right? Just 229E is an example of one. But it showed that individuals in households, individuals that were positive for SARS-CoV-2, if they had a relative in the household and they were exposed to this individual, if they had T cells that recognized SARS-CoV-2 in general, in other words, they'd previously been infected with other coronaviruses, those individuals are less likely to be positive down the line, which is just interesting, right? So all it means is we need to pay attention to these other T cell epitopes, and perhaps we need to include these in our vaccinations in the future. That's all that really means, right? It doesn't mean that, natural immunity is better. It doesn't mean that at all. It just means that in this scenario, right, you could see that these people are less likely to have XYZ, and it probably is because of that cross-reactivity. It's really interesting stuff.
That is interesting because it explains why we've been looking at immunity and maybe in certain ways, like with antibody, we've all talked about antibody readings, but we know that immunity is complicated and rich and diverse, and you have T cells and all these things that are remembering, your body's remembering what it's been through. Do you think we'll ever get to a point where there could be an antibody reading, or not? I mean to say antibody, it could be any sort of reading when it comes to natural immunity that would say, hey, this person is, is more protected than someone that has a naive immune system to SARS-CoV-2. Can we ever get there with this particular, like this coronavirus? We haven't gotten there with the flu. So I'm just curious about that. Mm-hmm. Do you ever see that in the future?
It's tough, maybe. And then I think that we make it seem like people don't have options. People are going to take their options, right? So I have several patients that refuse to get vaccinated, which is fine. I'm still going to take care of them. So I will check their antibody levels to spike protein every so often, just to make certain that they're as protected. I feel like I have to do something, right? And I feel like at least me checking it allows me to have this conversation in case they change their mind. And a couple of people have changed their mind and been like, okay, I want it, right? But I think that eventually we'll probably get there because we'll have a better understanding of what level of spike protein is protected. We'll have an understanding of what level of other antibodies is protective. We'll have a level of what level of T cells is protective. So eventually we're going to get there. We're not there yet, but I do see us getting there at some point. But I also see therapies getting better, right? It's like when people go in with certain diseases, we have specific antibodies that will bind to that particular pathogen, right? It's kind of the same. It's gonna be the same thing for SARS-CoV-2. Like we're gonna have these therapies that do that. I mean, with the antiviral, it's so powerful. Other than the contraindications it has, which is for basically anybody who's older on a bunch of medicines, it works really, really well. So we're gonna evolve. We're gonna have better therapies in the future where, yeah, vaccination is extremely important, but you want to get to the point to where treatment is available as well for those that don't want to be vaccinated.
Well, and the treatment could be available to, I mean, just like for the flu, you could get Tamiflu if you've been vaccinated for the flu, or you're not vaccinated for the flu that year. It doesn't really matter, right? It's about a treatment that a doctor can give anybody, regardless of what their past choices, right? I mean, that's where, how close do you think we are to that, to being able to call the doctor instead of the doctor saying, yeah, Tylenol, like maybe some vitamin C, and then say, actually, here, I want you to take this for the next couple of days, and this should shorten your illness, and maybe even help you not have these lingering, effects that we're seeing, a lot of fatigue and kind of shortness of breath that can last, 3 to 4 weeks after infection.
Yeah, I think we're there, right? I mean, I've been giving the antivirals all week, right? And I've been for the last 2 weeks since they've been available. And you can only get them at CVS because apparently CVS is the only pharmacy in the country that has that contract. But you can give Paxlovid there, right? You can
that's
give
the Pfizer
That's the Pfizer
antiviral.
Yeah, that's the Pfizer antiviral. And I get a lot of questions surrounding ivermectin, right? What about ivermectin? It's cheap, it's easy. There's a lot of people using it, and there are a lot of people using it. When you look in a petri dish, ivermectin does inhibit some of the cytokines and some of the inflammatory products, right, in a petri dish. But it's at huge concentrations that we never reach with the PO dose that we're being given. And when you look at the randomized controlled trials, ivermectin was always combined with steroids. And so we already knew that steroids reduce mortality. So we never could separate that out. When you look at India, a lot of people say, oh, well, India is doing it. Well, they're not. So the people that I talk to in India, they say, no, we're not doing it. And I don't know where everybody's getting this information from. But I think that you have better options now. And please believe everyone, pharmaceutical companies can quite frankly, and Merck makes ivermectin, they can quite frankly change the name, rebrand it, and sell it to you at an increased cost if they felt that it was beneficial. And Merck has said it's not beneficial. They've looked at it a billion times. Plus, trust me, they wanted it to be. So when I look at a situation like that, that's when I really know, okay, this really isn't beneficial. It has nothing to do with, the drug company or big pharma or making money. Like they totally could. Just like they rebrand the EpiPen, they rebrand insulin and increase the price. They could do the same thing with ivermectin. So I think it's important for people to understand which drugs are available to them.
But when you prescribe that new antiviral, the Pfizer antiviral, do you also prescribe that steroid that you were saying that's also helpful for people? I mean, is it the steroid that is what everyone should be getting to, if that seems to be like a commonality, or no?
All right. So in that randomized control trial, they just use the antiviral. So they know that the antiviral does that. I tend to wait. So if somebody is infected, say somebody presents to me and they say, I have a positive test on today's Tuesday, today. I have a positive test today. I ask them this question. I say, when did you start having symptoms? They say, oh, I started having symptoms on Saturday. So then I assume, okay, so they're probably exposed 2 to 3 days before then. And then I count like 10 days because I want to give the body enough time for it to generate antibodies and T cells and B cells to recognize the infection before I give them immunosuppression like prednisone or Decadron. That's just me. If they're outpatient, right? Because if they're outpatient, I have some time, right? If they're inpatient, different story. And if they have infiltrates, different story. They've had it for a while. Generally speaking, those people have had symptoms for a while. It's rare that you see somebody that says, oh, I had symptoms yesterday, I tested positive yesterday, and now they have infiltrates all over the place. That's rare. It takes some time for that to happen. So that's what I do, just because I really pay attention to how the immune system works and what it needs to do to be able to get over things.
You have a patient here that actually joined us who says that she apparently got monoclonal antibody treatment from you and says that you're a great doctor. That's not a respiratory infection. I just swallowed something weird. Sorry, it's live, folks. This is what's happening. So let me see. There's a couple more questions that we have. I thought were great to get to as well. What if one of our audience members had this, and she went by Speckled Bird. So I didn't have a name for her, but I like Speckled Bird. She said that her husband was diagnosed with COVID, had symptoms, mild symptoms, seemed totally fine, but the lingering effects of COVID have continued. And this was a little bit of what I was referring to. She said that he has lingering cough, he has exhaustion. Now he's 10 days out. So what is the expectation for you when someone starts feeling better? I mean, are you noticing these long, even if with mild illness, because you would think like, oh, it's just a mild illness, I'm not going to feel the effects for a couple of weeks. Are you still seeing that people are seeing the effects much longer than, let's say, your quote unquote typical cold?
Yeah. 68, depending on which data set you look at. Like if you look in Italy, it was like 80%. If you look in the United States, like 68% of people continue to have persistent symptoms of SARS-CoV-2 kind of after they get over the infection. Generally speaking, you're through the infectious part like 7-10 days, 2 weeks or so, and they continue to have symptoms, whether it's nasal congestion, shortness of breath, cough, fatigue. Most people have fatigue, feel run down, have a little bit of brain fog. Now, yes, I see that, and we call that post-COVID syndrome, and there are certain therapies. What we do know about post-COVID syndrome is that there is a persistent cell population that tends to hang around. They're called T cells, and they have certain characteristics. In other words, the receptors hold certain characteristics. They're called CD14, CD16, CCR5 positive T cells that tend to hang around. And we tend to use medications that will kind of target inflammation, whether it's prednisone, whether it's a statin, whether it's an HIV medication called Maraviroc, which inhibits CCR5, fluvoxamine sometimes. These are all medicines that help with that inflammatory process and help displace some of those cells. It can be very difficult to treat and does take a long period of time to treat.
Natalie's saying that she's still testing positive after 10 days with COVID. And she's just wondering, does she still need to quarantine? We've had all that kind of confusion that was created about the 5-day quarantine and then masking for 5 days. Now I don't know, Natalie, if you want to jump on, you can jump on and talk to Dr. Rutland as well. How do you judge that? And should everyone be testing themselves at 10 days? Because not everybody has tests.
I mean, the honest to God answer is, I don't know how to judge that, but the common sense answer to me is, if you're feeling better and you have no more symptoms, odds are, and you had symptoms before, odds are you're probably not contagious. You can go out in the world and live your life. It also kind of depends on what test you got. Did you get a PCR? Did you get an antigen? I don't really know how to judge that, because at least for me, Does anyone
know, Dr. Rutland, though? I mean, we've been told a bunch of arbitrary timelines. And I just want, I understand why people are feeling like, hey, if I have super mild symptoms that aren't anything different than a regular cold, like, should I even be quarantining at all? How does this all work? Does anyone really know at this point? Because it's not like we've felt a great deal of confidence coming from those in power. Listen, it's not political. I'm just saying, I've witnessed it. I've been sitting through the briefings and things are changing. There's not an explanation for the change sometimes.
Yeah.
So what are we supposed, one person on our feed just said, hey, my child's in daycare. They have a cold every single month. Like, that's just what happens. Like, when do we start viewing this as that and not as COVID as it is right now?
Yeah.
How do we do it smart?
Things change so quickly when you have an infectious disease that causes, inflammation spreading as fast as it is, right? And so you have a disease that's constantly evolving, and guidelines are written and things are said by political figures, and they're almost like set in stone. Like, oh, he said this 4 years ago. And I'm like, dude, that was 4 years ago. Like, the Raiders coach got fired for something that he wrote 11 years ago. Right? I mean, I'm just kind of like, people can change. And when you look at this virus, this virus can change and people can be wrong. In the beginning, Fauci said, oh, we're not going to have to mask. A month later or 2 weeks later, he said, oh, we have to mask. Like, because things change. And in medicine, I'm used to things changing all the time. Even though we round like once a day and we write notes, people get sick, things change, disease evolves. The problem is we're trying to take these quick snapshots of ever evolving pathology. And it's very difficult to come up with guidelines. Like, I would even go as far as to say the guidelines that we have written and that are set in stone for the pandemic were written for the Delta variant or previous variants. They weren't written for Omicron. I don't think it's the same. Even though we write these guidelines as if they are all the same, they are not. But it's very difficult, right? I personally believe that the most powerful statement in the English language is I don't know. What does I don't know do? It lets you know that you need to do some more work. Things are always changing, and it gives you this awareness that a lot of people don't like to have, right? Because we always want to instill confidence and make sure we know what we're doing. I get that. But I think sometimes it's okay to say, I don't know. And I honestly feel that leadership probably should have said that a lot more. I don't know. We'll see where things go. We'll see how things evolve, right? And so with this condition, we're wrong. I remember the first video I ever did on coronavirus. I honestly sat there and I looked in the camera and I said, oh, it's not going to be a big deal. Don't worry about it. I was wrong. Luckily, I didn't have, the following, but like, I was wrong, right? I'm allowed to be wrong, but we put these people in such high regard that they're not allowed to be wrong. This thing is changing, right? People are asking questions about masks. What do I do with my kids? What about school? I'm going to be honest with you guys. I got 2 kids. I got a 9-year-old. I got a 6-year-old. Them not being in school affected them in ways that I will never get back. My 6-year-old is struggling to read. She missed kindergarten. Like, she's struggling to read. Like, and maybe I'm not a good parent. Maybe I don't read with her enough. But I also have to go to work and all of these things that parents do. But like, I don't know. That's why I try to use common sense when I answer these questions.
Well, and you listen, you're getting a lot of people. I hear my 2-year-old. I'm going to go grab him. I'm going to bring him in here. And I think a lot of people are applauding that because most people, and this is something I think I've learned too as a journalist in this period, is that yes, you have a lot of people on that are black and white, right? They're like, oh, we're doing this is the right thing, and you're wrong, or I'm right and you're wrong. But there's a lot more people in the middle that are looking at these two sides screaming at each other that are just like, y'all are exhausting, and I just want to do the right thing. Like, yeah. Can I go out on day 7? Like I don't have any symptoms. Like, or I did this, but it didn't work. Like, I just want to do the right thing. So let me give you a question. I'm going to go grab True because I can hear him. I guess one of the questions, and you are seeing a lot of this on the feed still, is this question about masking, because it is something that's been batted back and forth. N95, cloth mask. Now the cloth masks aren't good enough. How would you approach that? You go ahead and give them a little something. I'm going to go see if I can grab my little guy.
She knew that topic was going to be long, so I get to just talk. The masking thing. All right, you guys, you got to use the common sense here. Just get a mask, a surgical mask, a Henry mask, whatever kind of mask you like, and wear the mask when you're around other people. That's it, right? Masking does protect you from viral loads, right? You're not going to be as loaded with virus as you would be if you didn't have a mask on. So I really feel like masking is appropriate. Masking is appropriate for children at school right now. Masking is appropriate for adults that are around other people. So I think masking is important, and I think we need to do that. Oh, there he is. Hey, buddy. How you doing?
Who's that? Can you hear him? Who is that? I told you. Hold on. Let's see if you can. Can you say hi?
Hey, how are you?
Who's that? What's his name? Doctor. This is what we need. This is what we need here. Look at you. Hey, look at the doctor and you stop coughing.
How are you? You doing okay?
How are you feeling? He said.
Are you feeling okay? Oh, yeah.
I cough.
You cough?
Yeah, no, that's the microphone. That's not what I'm using. Oh, here. This is not the microphone I'm using right now, but this is. Yeah, there you go.
Nice.
What, any sort of final thoughts, Dr. Rutland, before we go, of like ways, like let's just talk about getting through January, like getting through the next couple of weeks, like what, any sort of guidance to that period, whether it's navigating the headlines or navigating colds in our own household.
Yeah. Wear a mask. It reminds me that if you have a kid who develops croup, like True, when they get respiratory infections, and you know that there's certain medications that work, go get the medications now, right? Don't wait for it. Just go get the medications now. So that way, as soon as you hear it starting to develop, you can start it, right? A lot of physicians operate on, oh, let's wait and see until you get this. Right now, you can be proactive, right? Try to protect your family, try to protect your children. Again, your kids, they don't get very sick. They'll have that. You can see he has a normal attitude. He's still smiling. He's still doing his thing. He's still acting like himself, right? But he's just coughing. That's a good sign. It just means that, like, okay, I got a cough. Like, I'm going to deal with this cough, and I'm still going to laugh. So those are all good signs. You guys know your family, you know your friends, you know your children. So just be proactive about it, right? Protect them with the masking, protect them with the distancing, go to work, do what you got to do, but do what you can to protect within reason, right? Within reason and convenience. School is important. I understand why we have to continue to go to school. Masks are important. I understand why we have to mask. You guys understand that now too. Vaccination is important. If you want it, great. Go get the vaccine, go get boosted. If you don't, know your risk factors for severe disease and know where you're going to go if you do develop SARS-CoV-2 positivity or you have a strong exposure to SARS-CoV-2. Know where you're going to get the monoclonals, know where you can get the antivirals, who are you going to call, okay? Those are the things that are important, right? In terms of protecting your immune system and allowing it to function as efficiently as you can, eat things from the produce section. You can take vitamin C, you can take vitamin D, you can take zinc, all those things that are important cofactors for the white blood cells to be able to work appropriately and efficiently. You can do those things, that's fine, right? But those are the things that I would say are going to protect you as much as, not as much as social distancing, but like social distancing, right? I would just want you guys to just look out for yourselves and your family members and understand their risk.
Some great advice. Thank you, Dr. Rutland. Let's do it again soon. I'm going to run and grab.
I'll see you later.
It's great to see you guys. Thank you so much for all the questions. Thank you for the time, Dr. Rutland. And we're going to make sure to have this video posted on YouTube and on the website so people can watch it again. All right, guys. Have a great rest of your week. I'll talk to you soon. Dr. Rutland, I'll give you a call.
All right. See you.
Bye.
Bye.
Quick, concise, nonpartisan, smarter news, a refuge from the storm. I'm Jenna. Thank you for choosing smarter.